Okay, so we are recording, and this is a session that we are doing. Welcome to our Gastro CME. My name is Joash. I'm one of the Gastro Fellows, and joining me today, beside me, is the one and only Professor Lee Yeong Yeh. We are both from Hospital Pakar University Science Malaysia. We are actually in the room together with also Dr. Amri, a senior consultant gastro, and also with my fellow friends and fellow colleagues here. Today's session is about Anorectal Manometry and the London classification. A lot to cover, so let's see how it goes. And if I make any mistakes during this recording, properly beside me, he's going to bash me, and I'm going to get it from him. So let's see how we go from here. So a little bit about the anatomy of the pelvic floor and the anatomy of the anorectal region is that the pelvic cavity, apart from the bones, is that it is being surrounded and held in place by dense layers of muscles, skeletal muscles comprising of your levator, ani, your gluteus, and also at the posterior, at the floor of the pelvic or the pelvis, you have the levator, ani, which helps to keep the external anal sphincter and it keeps the rectum in the correct position. So it's a strong interplay of many layers and many different groups of muscles. There are three important muscles that we want to spend a little bit time talking about. And the first is the internal anal sphincter. The internal anal sphincter is a circular muscle layer of the rectum. It is an involuntary muscle, and it is thicker at the anal canal. Now, the internal anal sphincter being involuntary in nature, it is responsible for the majority, 7 to 85% of the resting anal tone. And how it creates the anal tone is through a slow twitch, a fatigue-resistant, smooth muscle activity. And we have been able to measure the mechanical activity generated by this slow twitch, and it goes up to as many as 35 cycles per minute. And sometimes you can also be able to appreciate ultra slow waves at 1.5 to 3 cycles per minute. So the internal sphincter is labeled over here in purple, and that is, and you will see that it is lining the inner layers of the rectum. Whereas the external anal sphincter, it is, as with its name, it is located slightly externally. It's externally, and it is a longitudinal muscle. It is a voluntary striated muscle. There are three segments and the three groups of the external anal sphincter: subcutaneous, which is located lowest; the superficial, which is located slightly higher; and the deep, which encircles the upper end of the anal canal. And the deep and external anal sphincter actually is also part of the puborectalis muscle. In one of the researches which has actually contributed by Professor Lee himself, they map out on MRI imaging, they managed to map out that they found that the external anal sphincter is actually part of the puborectalis. And instead of the usual donut configuration that we are familiar with, it actually is being mapped out adequately to form a purse string morphology rather than just a donut. So therefore, the puborectalis and the external anal sphincter has a very, very close relationship. The external anal sphincter also is being part of the puborectalis muscle. So let's take a deeper zoom. Let's take a deeper zoom into how it looks like from a cross-sectional imaging. Again, in purple over here in this box here, you see the internal anal sphincter. And external anal sphincters, you have the subcutaneous at the lower. You have the subcutaneous, which is at the low. You have the subcutaneous, which is at the lowest portion, the superficial part, and also the deep part. Now, if you look closely, what you will see is that you will see an overlapping area between both the external and the internal anal sphincter. And this is a very important phenomenon where the overlapping actually helps to promote and to preserve continence. And in one of the images later in the manometry I'll show you is that we see a patient that may have where they have anal hypotension. You may find that there are some defects or some separation between the internal and the external anal sphincter. The puborectalis muscle are fibers that form from the two levator ani muscles that form a sling, and is attached to the front of the pubic bone. It passes around at the junction of the rectum and the anal canal, and when it constricts, it pulls the rectum forward to create an acute angle. So therefore, the anorectal ring consists of the puborectalis muscle, the deep layers of the deep segments of the external anal sphincter, and the internal anal sphincter. So what I was illustrating earlier on with the puborectalis sling down here in this image over here, taken from one of the papers published by Professor Lee and also in his textbook, is that we find the puborectalis muscle located at the junction of the rectum. And this sling over here, when it contracts, it creates an acute angle that not just constricts and tightens at the rectum, but it also creates an angle, an acute angle, and therefore the fecal material that is within the rectum is not able to flow out. The layers of the rectum consist of the inner layers consists of columnar epithelium, which is sensitive to stretch, and at the external layer, It consists of an ectoderm, which is sensitive to pain, touch, and temperature. So this whole adage of not performing hemorrhoidal bending for external anal sphincter for external hemorrhoids is because it is painful. It's sensitive to pain, touch, and temperature. So that's the very reason. Whereas for the internal layers, there is no pain, touch, or temperature sensations, but it is sensitive to stretch. A very important phenomenon, which is what helps a normal patient physiologically to maintain continence. Now, if we are to classify the function of the anorectal, there are two important functions, and the first being continence, the second being defecation. Continence meaning that you keep your fecal material inside the rectum, it doesn't come out at the wrong time when you are not appropriate, and how it does that is that there are two ways that it happens. The first is through the anatomical function. The anatomy of a normal human being, at the rectum, you have the valves of Houston, which is transverse valves over here, which helps to slow down and to cause as a brake for the fecal material that is coming in. The anorectal ring, which gives you the acute angle of the rectum that prevents feces from coming out accidentally, and the anovascular cushions, which creates the tone that is required to maintain the anal sphincter contraction. Physiologically, there's a concept of sensation and perception of rectal content. When you feel like going to the toilet, you are still able to hold it in and you're able to go to the toilet at the appropriate time. And periodic rectal motor activity is a type of retrograde activity whereby it is small impulses, small electrical activities which causes constriction of the muscles that actually pushes the fecal material backwards instead of going downwards. And this is a very important motor activity that happens during sleep to prevent feces from coming out or going downwards into the anorectal region when you are sleeping. You wake up, you go to the toilet, and that is because of the PRMAs. Whereas in the concept of defecation, it is about letting the poop out, letting the fecal material come out at the appropriate time. And there are two components to this. The first component is the push. You are pushing the trolley outwards. And this push, it involves the increased intra-abdominal pressure and increased rectal pressure that helps to push the fecal material from the rectum down into the anorectal region out of the external anal sphincter. But for that to happen, for fecal material to be able to be adequately pushed out, the door must open. You're pushing a trolley through a door. The door must be able to open. The anal sphincter must be able to relax. The rectum must be able to go into a straighter position, a more obtuse angle. And therefore, there are two mechanisms that happen. The first is the relaxation of the pelvic floor and the anal sphincter muscles. The door opens. And the second is the descent of the pelvic floor, the relaxation of the puborectalis muscle that helps the sling to turn from an acute angle into an obtuse angle, and therefore allowing the fecal material to flow down.
Yes, far so good, well done.
Okay, now let's talk about the manometry. With this understanding of the simple anatomy, let's talk about manometry. Now, the indications for manometry is that if a patient, you are dealing with a patient with chronic constipation and you're sitting there in your mind, you're suspecting, am I dealing with a dyssynergia? Is my patient's door not able to open properly? Is the patient not able to push adequately? I'm suspecting dyssynergia, I'm suspecting a propulsion problem. This is a patient that may benefit from manometry. Or if a patient is experiencing incontinence, maybe a muscle problem of the anal sphincter, or there's some problem with the anatomy, this is a patient that will benefit from manometry. And of course, if you're a naughty trainee like me, you will want to do more procedures. So, let's start off with the probe. I put up two probes over here, one by Diversitech on the left and Labori on the right. In principle, the probes look different, but the principle of it functioning is similar. You have with you a long probe, and attached to it, you have many sensors, and you have a connection into your recording system. And over here is going to be a working channel where you're able to push air inside that can help to inflate a balloon. We will talk about the balloon shortly. What you have over here, these sensors are what we call piezo-resistive microelectrical mechanical system sensors. Sounds so chunky. Now, what piezo refers to is a pressing mechanism. So piezo means pressing. Piezo-resistive means this idea that if you press on something, it generates an impulse. It generates a charge. And therefore, the leads over here, in this image, the leads will be able to pick up the changes in the pressure from piezo-resistive sensors. And microelectrical mechanical system just essentially means that there is actually microchips that's inside that helps to interpret and to pick up and to detect the electrical changes, which eventually gets converted into images like either a waveform or a color plot imaging. Now, we talk about a balloon, and a balloon is important because this balloon over here, which is attached to the tip of the probe, will help us to be able to measure the sensation of a patient. Does the patient still is able to experience volume within the rectal region? Now, over here, this is the authentic, original balloon that appears on that comes with the manufacturer. It's an inflatable latex-free balloon, and it helps with the rectal sensation. Now, of course, because we are a third world country and we are not very, very rich, so what we have done is that we have designed a way where we are able to make our own balloon. What you see here is a condom, and the reason we use a condom is because it is able to inflate to reasonably high volumes, upwards of 300 mils of air. Inside, at the tip of the probe, there is a groove, and what we are using is that we are using sutures to tie a dead knot around the tip of the condom. And the reason that you have to tie it as tight as you can is because, as you are seeing, we are trying to inflate air inside. So if the suture end is not tight enough, it's not going to be airtight, air is going to leak, and you're going to lose the balloon effect. Not only do you want to tie it tight and you want to test it, we also do what we call the underwater test. We will eventually put it inside a tray of water to see if there are any bubbles. And the negative bubble test means that me and Hizami have done a very, very good job. That very nice Garmin watch actually belongs to Hizami. I'm sure he's going to see this video later, that's why I wanted to specially highlight him. Now, what happens then after that is that we put the probe, the patient will be lying in the left lateral position, comfortably on the bed. We put the probe, we set it up to our tower system, which is our CPU, our reading unit, and then we will insert with the balloon with adequate amount of gel and lubricant. We insert it gently into the per-rectally. No sedation is required for this process, and if all goes well, if Joash behaves, he does the process properly, he doesn't go and sembang kuat with the patient, it can be done within 20 to 30 minutes. And when we place the probe inside, what you're seeing is that you see this very nice waveform over here. You see a blue column at the bottom, a blue column at the top, and blue corresponds with low pressure. So the reason why it's low pressure down here is because we deliberately leave two sensors outside of the anal cavity so that we are able to read. Imagine if all the green is all the way bottom at the down there, it's going to be quite hard for us to read. That's why we leave two sensors outside. And the upper two sensors there refers to the area where it's inside the rectal cavity, a low pressure area. This green area is what we are measuring. We are measuring the anal sphincter activity. So if you place it correctly, this is what you are able to see. Now, apart from manometry, we also have to do a second step upon removal of the manometry, and that's called a balloon expulsion test. Now, the balloon expulsion test is what we call a uniform assessment of the general defecation function. Can the patient pass out a balloon on his own effort? Again, this is a manufacturer-ready balloon. It has a latex-free balloon which is attached here. You inflate it with air, it kembongs, you put it inside a deflator, you inflate it inside the rectum, and then you give them some time, they'll sit on the commode, and they'll attempt to pass it out. As usual, because we are third world, although we are Apex University, we are still reasonably third world. So with cost as the issue, we use a glove, the tip of a glove, and we tie it with a suture. Similar concept, make sure that it is tied nice and snug, and make sure that there is no leaking that happens. So we attach this device, this little thing to a three-way stopcock, and then we inflate it, keep it locked in a position, and then later on we will do the underwater test again. So again, this is Hizami's hand together with Puan Aslina and also Puan Siti. So therefore, so the balloon expulsion test, after we remove the manometry, we will insert the balloon. We will insert this little makeshift device in per-rectally, and then we'll inflate it, lock it in position, and we get them to sit on the commode, and then we give them a timer. And the instructions that we give them is that try your very best to be able to poop this little balloon out, and then we record the time. So this is a balloon expulsion test, which is a test that we do on top of the anorectal manometry. So let's talk about performing the manometry. So far so good, huh? Okay, no good, also we have to continue because we're recording. So let's talk about performing the manometry, and the manometry is going to be based on the 2020 paper written by Scott et al., a beautiful paper which has managed to successfully stand the test of time. Now, before 2020s, it is not that there is no such thing as anorectal manometry. Anorectal manometry has been existing for almost 4 to 5 decades at the time of the publication of this paper. But the problem was that there was no standardized guidelines. nor were there any recommendation on how is there a standardized way of interpreting anorectal manometry. Many reasons why this happened. It could be because that technology has made it so much better that the anorectal manometry was able to improve, the sensors were getting better over time. Or it could also be that there were so many new technologies that came into play in the introduction of manometry in the interpretation, like color-contoured pressure topography plots. So inspired by the Chicago classification, as London classification went to press, they were inspired heavily by the experiences that they drew from Chicago 3. And therefore they came up with an attempt to standardize the test, the protocol, and the reporting. And they broke down manometry into 4 important sections, which we will go through one by one. This is the flow of an anorectal manometry, the steps that you do. I remember the first time I was seeing this, the first time that I came across anorectal manometry when I was a second-year fellow. That time also Professor Lee came all the way over to Sarawak, and I remember going through this, I was like so overwhelmed. It's like, wow, so much, it's crazy, the number of steps you have to do. So, but once you start doing it, you realize that you actually break it down into simple, short segments. And the simple short segments start with a resting face. You tell the patient, just lie down. You insert it inside. You lie down. Don't do anything. Don't talk. You can play with your phone. Don't cough. Don't sneeze. Do nothing. And the purpose of the resting face is really to get a baseline measurement of the anal sphincter activity at rest. Don't forget, as you insert a probe inside the perorectally, sometimes the patient gets a little bit agitated. Muscle twitching happens. The smooth muscles are not able to adjust themselves. So the resting face gives them an opportunity for them to get used to it, and then you are able to measure the baseline activity. Don't forget that the resting phase actually preceded by a stabilization phase. That means the body, they give the patient chance for the body to get used to the probe being inserted before you start measuring the resting anal pressure. And what you're looking for is the anal tone. This is exactly the same picture as I showed you earlier on. What you're looking for is you're looking for the resting baseline pressure. You can see over here the mean anal resting pressure, which is 54 millimeters mercury, which is within the normal range of Labori system, and the anal canal length of 4.7 centimeter, again within the normal range, accepted range of the Labori system. After a rest, then you tell them to start doing some work. You start off by doing something simple. You tell them to squeeze. Now in Malay, in a colloquial word, the word that we tell them is kemut, and kemut means close. Sometimes I take it a step further, I will tell them to actually spell it out to them what I want them to do. You are not yet at the toilet. There is poop going to come up, but you're not at the toilet. You have to hold it in. Close, tutup, kemut. So these are the words that I also use to help them get the right concept in. And what we are looking for is we're looking for the voluntary effort to contract the anus and the pelvic floor. What we do 3 short squeezes. 3 short squeezes, very short, only 5 seconds. 1, 2, 3, 4, 5, that's it. And then after that, you tell them to relax. You wait for 30 seconds, and then you repeat the process. If you do the short squeeze properly, and if the patient is able to mount a normal anal contraction, this is what you'll see. Over here in red corresponds to increase in pressure. And what they see here is the patient has successfully kemut, a very good squeeze. You see that the squeeze pressure increases by 68 millimeter mercury, more than the cutoff of 60. And therefore, this patient has a normal anal contractility.
Yeah. Just to mention that the squeeze itself must be free from any abdominal effort. So it's why you see up there, there's nothing from the abdomen. It's purely a function of your anal muscles. Because some patient may be cheating, they will use the abdomen to help them with the squeeze. That is not correct. Yeah.
Now, short squeeze not being enough, we want to torture our patients a little bit more. We tell them to do a long squeeze, endurance squeeze. And the endurance squeeze is really to look and see the muscle activity and the muscle function at a fatigable state. So this time, it's 30 seconds long. Now, the instructions that tell them, you're going to hold it very long. I need you to hold it for 30 seconds, long time. And if you're a Chinese, you imagine you're going to be like when you talk to them, when you tell the patients, come on. Sometimes I get so excited, I just hold my breath together with the patient. So you're not supposed to hold your breath, right? Because it's just an anal method. But sometimes we get so excited, we tell them to hold. It's like almost like doing a yam sing in a Chinese restaurant. So one squeeze, if they can do it properly, 30 seconds long. And because you are straining their muscles so long, the next test that you do, you must give them a 60-second rest. So you torture them, you also let them rest a little bit longer. So if you do it properly, this is the pattern that you will see. You will see a pattern. I brought up the waveform at the side of this so that we can. So because this is how we use, it's easier for us to be able to map out when does the descent actually start. So what you see over here, you see the initial, in my laser pointer, you see that there's an initial mount of the anal sphincter, zoom, the initial mount, and then after that it goes into a state of plateau. This is the stable phase, which is measured by, you can almost draw a straight line across, correct? And that is what we are looking for. Before the patient goes into a fatigue, what is their baseline anal sphincter contraction ability? And this patient is able to, not bad, he did really well. This patient is able to contract for 22.3 seconds, which anything more than 20 seconds, we say that the endurance squeeze is normal. After they squeeze, now we want to look at the rectal function. We want to look at the rectal, we want to look at the anal function. We started by telling them to cough, batuk. Now, the cough reflex is essentially to see whether or not, what happens at the anal sphincter when we abruptly increase the intra-abdominal muscle through a cough. You cough, the diaphragm straightens, your intra-abdominal muscle increases, and then everything presses down very briefly without them trying to poop. What happens? There are two things that happen. The first thing is that you will see an increased intra-abdominal muscle, intra-abdominal pressure, which translates to increased rectal pressure. But consequent to that, you will see the second phenomenon, which is an increase in the anal sphincter muscle. The anal sphincter will contract as a reflex to the cough. A normal cough reflex means that both increases, but the anal pressure sphincter increases more than the rectal pressure. Now, in our setting, what we find is that cough, so many types of cough. You can have a very cute, a very chomel, a very polite cough. You can also have the cough like a typical alpha male, and the results become very, very unbalanced. So what Prof. Lee has designed was that he told patients, he gave patients a balloon and he tells them, blow into the balloon. In one deep breath, one strong breath, blow as fast as you can to simulate a constant pressure of the intra-abdominal muscle. And if done correctly, this is what you'll see. You see that there is an increase in the intra-abdominal muscle pressure translating to an increase in the rectal pressure. But you also see that consequent to that, the anal sphincter pressure also increases quickly to close. And this is a measure to prevent from stress incontinence. What you see down here is that you see that the anal pressure increases more than the rectal pressure, and therefore this is a normal cough response.
Yeah, so it's like a stress test on your anal sphincter. If you pass the stress test, then the anal sphincter will contract. If it fails, then it will not be more than the rectal pressure. So the whole idea is a stress test, but also it can test the local reflex. Yep.
Mm-hmm. After the cough, we tell them to push. This is where we simulate their defecation. We tell them to push. You are now in the toilet. I want you to push. And the word that we use in Malay is teran. Again, me being the naughty doctor I am, I'll tell them, you are already in the toilet, sampai toilet dah. Tolak najis itu keluar. Berak bagi dia keluar. The word that we use is teran. 3 pushes, 15 seconds each, and they have to rest 30 seconds in between each push. As I was preparing for this session, only I realized I actually have very little normal defecation anorectal manometry. So I had to use the one from the London classification. What the London paper describes as a normal one. What you see over here, you see there's increased intra-abdominal pressure and increased rectal pressure. What you see over here, this rectal, remember? So increased rectal pressure, pushing. They are using their intra-abdominal muscles, intra-abdominal pressure to push. The rectum gets pushed down. It turns from blue to green. But if you look carefully over here, look at what is going on at the anal sphincter. You see that the color is turning light blue. From what was initially a yellow, it now starts to turn green and it starts to turn blue. This is a relaxation of the anal sphincter. And it makes sense. Again, this is physiological. For fecal material to go out, there must be a push mechanism and the door must be able to relax. So this is a normal defecation process. And finally, at the very end of it, you test for their sensation. Now, what we do in our center is that we do 2 things at the same time. We test for the RA, which is your rectal anal inhibitory reflex, and then you also test for sensation at the same time. How we do it a little bit different from London is that we straight away start with 10 mils. We start with a 10 mil inflation at the balloon. Remember the balloon that we tied to the manometry? Inflate 10 mils, inflate 10 mils, inflate 10 mils. And what we are looking for immediately when we inflate the 10 mils is that we are looking for a decrease of pressure at the internal anal sphincter. If you push air inside and you see that it transiently decreases, this is what we call a normal Ra index, a normal Ra reflex. After we have the Ra, then we proceed to perform the rectal sensations. We increase rectal sensation by 10 mils, 10 mils, 10 mils until the patient tells us, yeah, I feel something that doesn't go away. I feel something in my rectum that is lasting a little bit longer. 5 seconds, 6 seconds, it's not going away. And what they coined this is coined as a first constant sensation volume. The first volume where you start to feel something that doesn't go away. Maybe a small poop. After we already record that first constant sensation, then we increase a little bit faster because we can't be pushing 10 mils every now. It's going to take us forever. So we increase it to 30 mils. We increase it to 30 mils until the patient tells us, yeah, now I feel like I want to pangsai. I feel like I want to defecate. And what we call this is the defecatory desire volume, DDV. Not happy enough, we continue pushing in 30 mils until they tell us, I cannot, I need to go to the toilet, I'm uncomfortable, I'm in pain, I need to go. And that is called maximum tolerated volume. Now let's go back to this graph here. In this graph here, we established that the Ra is present at 10 mils. Well done. Now, we put in 10 mils, we put in another 10 mils, and at 20 mils, the patient tells us, doctor, I feel something, not going away. I have a sensation in my rectum that is not going away. So we mark this 20 mil as the first constant sensory volume. FCSV as established, we increase the volume by 30 mils. Next, we go 50 mil. Summer, I don't feel like going to the toilet yet. Increase to 80. Nah, I'm fine, I don't feel like going to the toilet. At 110, doctor, I feel like I need to use the toilet already. I need to go to the toilet. We mark this as defecatory desire volume. Can still tahan, can still hold it in. I don't have to rush to find a toilet, but I feel like if I need to go to the toilet, I'm comfortable. We increase another 30, and we increase another 30, we increase another 30, and at 200 mils, the patient starts waving his hand. The white flag goes up. I cannot, I really need to go. You have to stop, I need to go, I need to poop it out already. And this is called the maximum tolerated volume. 3 volumes to tell us the rectal sensation. So far so good? Okay? Alright. Now let's interpret the results. The interpretation now, the fun part is over, correct? The fun part is over already. Yeah, the patient is very happy. We tell them to do it, everything. And then now we have to interpret it. Now the order of interpretation based on the London classification, it breaks it down to 4 main components. The first component is Ra. Ra, present or absent. Easy peasy. The second component of anal tone, the third component of rectal-anal coordination, and finally rectal sensation. They have to further classify it to major finding, minor finding, and inconclusive finding. Let's start with Ra. We talked about the Ra earlier on. We put in 10 mils, you put in 20 mils of air. You see the decrease in the internal anal sphincter. What is that for? The purpose of this reflex is actually a sampling of rectal material. The internal anal sphincter has sensors, has mechanosensory receptors that's able to detect whether or not is this gaseous, is this liquid, or is this solid. So for a brief moment, just briefly enough, the internal anal sphincter opens up slightly so that it can be able to check and see what is this going on. So that to decide whether or not do we want this to pass, can we let this pass like it's a gas flatus. Okay, you can pass, you are safe to pass, open, fat, boop. Or is it not safe to pass? Oh, it's going to be for the solid material. Close, close, close. We are not in the toilet. Close back. So that is the purpose of the Ra. Now, although London classification never mentioned the number, but other papers have generally accepted between 20 to 25% reduction of the internal anal sphincter relaxation refers to a present Ra. Document the Ra. If the Ra is present, well and good. If it is not present, you think of 2 things. Childhood, long-standing, chronic constipation, you have to start thinking, are we dealing with Hirschsprung disease? Or if it's a very elderly patient who is consistently always having constipation and there's large fecal material, maybe they're having a mega rectum. You need even more volume to be able to pick up a Ra. In terms of London classification, it is very straightforward. It's either yes or no. If it is yes is present, normal. Not present, major finding, rectal anal areflexia. So far in my time, in my limited experience, I haven't come across a rectal anal areflexia yet for now. Next, part 1 done. Let's go to anal tone and contractility. There are 3 possible diagnoses that you can come up with. Anal hypertension. The door is too tight. Even at rest, the door very ketat, very tight. Don't want to open. And that is resting pressure greater than 101 if you're using the Labori system. Anal hypotension. Very loose, very lax. Door don't want to close. Resting pressure less than 33 millimeter mercury according to your Labori system. Or there could be anal hypocontractility. You tell the patient to squeeze, you tell the patient to kemut, still don't want to kemut. Doesn't close very, very well. So this is a patient, an elderly lady, an 80 years old lady who is having a lot of diarrhea, who is having to rush to toilet, cannot hold it in. What you see over here, you see two very distinct waveforms. Remember just now when I showed you all the manometry images, it's all green in color, correct? Look at this color here. Bluish lah, bluish. I didn't adjust the pressure colors. Bluish. The green also very pale. And then you look at the mean anal resting pressure, only 23. Very, very low. You can even map out that this is the external anal sphincter and the internal anal sphincter. There is a separation. This is a patient with anal hypotension. And what it means is that over here, the anal sphincter muscles cannot contract, it cannot constrict. That's why the fecal material will just keep on flowing out. Maybe they know that it's coming out, that's why they have to rush to the toilet. Anal hypotension. So therefore, London classification, if a patient has anal hypotension, it is considered a significant finding. It is a major finding. If a patient has anal hypertension, it is only a minor finding. And as I was reading the paper, I realized that they actually didn't cover anything about endurance squeeze. What does endurance squeeze tell us? We even had this chat before with Prof. Lee about endurance squeeze. Where do we fit it in? Because it's not part of the guidelines. So what we do now is that we put in a statement that, oh, if everything is normal, the anal contraction is good, pressure is good, but they cannot do an endurance squeeze. We just mentioned that, abnormal endurance squeeze.
Yeah, so the endurance, like the name suggests, is supposed to measure the stamina of the muscle. So in someone who has a fecal incontinence, if they can have poor anal tone or hypotension, they can have a poor contractility or hypocontractility. In patients with fecal incontinence, they will also have difficulty in maintaining the endurance during an endurance squeeze. So that's the whole idea. All these findings are giving us clue to whether this patient has a fecal incontinence or not. You are right, the endurance squeeze is not in London 1.0, but we are working on the London 2.0. Hopefully they will put in endurance squeeze and give us a more understanding on what we're really measuring.
Stay tuned, London 2.0. Okay, let's continue. So the third part, remember 4 parts, right? RAIR, done. Anal, done. Now let's go to rectal anal disorders. How is the coordination between the rectal push, propulsion, and how is the coordination between the anal sphincter relaxation? Now, remember we started off by doing a manometer, and then after you do the manometry, you pull out the manometry, you insert a balloon inside for them. And the first thing to look at is a balloon expulsion test. Balloon expulsion test gives you an overall impression, an overall understanding. Can the patient pass poop? Part 1 may not be normal, part 2 may be a little bit inadequate, but in general, if they are able to pass the balloon expulsion test to a large degree, they are still having a preserved defecation function. So the balloon, we start off with a balloon expulsion test, and anything more than 2 minutes is considered as abnormal. Anything more than 5 minutes is considered failed balloon expulsion test. Then you look at the rectal pressure increase when they simulate a defecation. When the patient push, when you tell them, "Turan," does the rectal pressure increase above the lower limit of normal? If it doesn't increase more than the lower limit of normal, this is considered abnormal propulsion. The rectum is not able to push the fecal material out. And then you look at the anal pressure. Does the door open? Does the anal pressure decrease? If it doesn't decrease adequately, then there's a dyssynergia. The door is not opening properly. Dyssynergia. Now, ironically, while this seems to be the most common problem I experience for my manometry patients, all of these are only minor findings. No major findings. I don't know why. So you look at all of this, right? All the findings over here, abnormal expulsion, abnormal expulsion with poor propulsion, only minor finding. Number 1. Number 2, there is they don't only expect you to have a normal, what if a patient has normal expulsion, but individually they have abnormal propulsion? Also not part of the guidelines. So what does a dyssynergia look like? In this patient, we told the patient to run over here at this point of time. We asked them to run. You see that the rectal muscle pressure increases. Well done. So the propulsion is present. But look at the anal sphincter. Remember this band here is the anal sphincter? Contracts, closes up. So when the anal sphincter closes up, no matter how much force you push, you are pushing against a closed door. You are not able to pass the motion out properly. So this is a patient with a patient with a dyssynergia. And what happens in a dyssynergia is that although the patient is trying to push, but the anal sphincter is closing. The anal muscles are not relaxing, and therefore pushing against a closed door is a futile effort. And finally, we talk about rectal sensation, the 3 sensations. When do you first feel something that doesn't go away? When do you feel like going to the toilet but you're still comfortable, still can tahan, still don't want to go yet? Or when is it you cannot stand it, it is coming out, it's just a matter of time, you have to go to the toilet, maximum tolerated volume. If you are feeling the sensations lower than the lower limit of normal, that means normal people, 110, 150 mils feel it, you are feeling it at 20, 30 mils. That means you are having a more sensitive rectum. Your rectal sensation is more sensitive than usual. That is rectal hypersensitivity. Patients, most normal people, at 200 mils, they feel, wow, I cannot tahan already, I need to go to the toilet. Yours, 300, 400, no feeling, don't feel like going to the toilet. Your rectum is not very sensitive to the volume. That is rectal hyposensitivity. For rectal hypersensitivity, you just need 1 out of 3 criteria, whereas for rectal hyposensitive, you need 2 out of 3 criteria. Rectal hypersensitive and rectal hyposensitive are both major findings. If you only achieve 1 out of 3 criteria for rectal hyposensitivity, that is a borderline inconclusive finding worth repeating or worth re-evaluating. How does a manometry report look like? This is how it looks like. So step by step. First, you start off with a brief history. We did this for a gentleman who is presenting a constipation, a little bit of a history so that nobody had to go and flip the whole file. Oh, what's the story? Don't know head, don't know tail. So at least you have a brief history over there. And then you interpret it according to the London protocol. Step 1, talk about the RA. Is the RA present or not? Easy, one word, RA present. Move on. Anal tone and contractility. Is the anal tone functioning? Is the doors closing at rest? Does it open? Does it know how to squeeze when you ask it to squeeze? You look at a cough reflex. Is there a normal cough reflex? When you subject the patient to a stress test, does the patient's anal sphincter pass the stress test? You tell the patient to defecate. Can the rectum push? Can the door open? And finally, you look at the sensation. Is the patient having a very sensitive rectum, little bit, also feel like going to the toilet? Or is it hyposensitive? High volumes, still don't feel anything. And that is how manometry reporting will look like. So, in summary, a little bit of understanding of the anatomy will help us as we proceed with doing the manometer. Preparation is key for a lot of us who have been doing the test ourselves. We realize that there's nothing that beats a good preparation before you subject the patient to a manometry. And there is nothing that is more important than practicing. Not just practicing the interpretation and the reporting, but actually doing the whole procedure yourself. So thanks to Professor Lee and thanks to his wonderful team in the lab, they have already had to put up with me. And I think we are getting better. I think I am getting better at doing the manometry. So with that, let's take any questions.
Oh yeah, thank you Joash for the wonderful presentation. So anyone have any questions about the test itself?
The endurance squeeze refers to which part of the anal manometry test?
So the endurance squeeze is part of the anal tone and contractility. So anal tone and contractility, this one. Okay. So first you start by short squeeze, then after that go endurance squeeze. Yeah. So do everything, settle all the squeeze, then only you go to the rest. So don't confuse the patient.
So this is what we call the protocol. Protocol is just how we perform the tests. Then there's a London classification to put all these protocol findings together and come up with a diagnosis. So there's a 2 component to the so-called London protocol and London classification. Anyone else?
Yep, go for it.
If let's say patient comes in with chronic constipation, young patient,
Yep.
do we still subject them for colonoscope, then only think of this test, or can we straight away think of this test before, in the event patient doesn't have any reflex signs?
Mm-hmm.
Can we straight away do this? Skipping the colonoscope, or you still do the colonoscope, then
Yep.
we do this?
Yep. Good question, especially when it's a young patient. So American guidelines, the AGA, the American guidelines, ACG, they have already been quite consistent about this. In the absence of red flags, in the absence of a need for a screening colonoscopy, for example, this is a very young patient, 20 years old, no family history whatsoever, no red flags. There is a possibility that you don't even need to do a colonoscopy, number 1. Number 2, if the chronic constipation is anything more than 1 year, upwards of 1 year, 2 years, the likelihood of a significant endoscopically positive finding is very low. So that is usually. That said, we have to also gauge the terms and the context of the situation. A lot of times the patients that come to us, these are patients who have been struggling for a very long period of time. They have done their own research, they are worried. So if a patient comes up to you and tells you that, hey, look, I'm quite concerned, I have friends who have actually died young from colorectal cancer, it is not wrong to do it. I won't say don't do it, but rather gauge the concern, listen to their concerns, and a colonoscopy is not wrong. As long as you have the indication, as long as you are counseled them adequately, I probably won't say no strictly. But if you want to strictly follow guidelines, the guidelines are quite clear. Young patients, no risk factors, no need for a screening colonoscopy, you probably can get away without it.
Yep. When it comes to chronic constipation itself, right, is actually a syndrome. It consists of a number of symptoms. It's not a disease, right? It's actually a syndrome. If your patient has certain symptoms that suggest a defecatory disorder, for example, the patient may tell you, I have straining. I strain, but my poop cannot come out. If the patient tell you, I have incomplete evacuation, I poop already, but I still feel something, it's not complete. Or they tell you the stool are hard, the Bristol stool is like type 1 or type 2. And the patient had told you that I've tried laxative, but it doesn't work. Then you need to start thinking whether this so-called patient with chronic constipation, does it have a defecatory disorder? In that sense, you might need to consider a test, an anorectal manometry test. But before that, of course, you can also do a per-rectal examination, something that we don't often do, but we should. Just by putting your finger in, you can just ask the patient to squeeze for you and push on your finger. If the patient is, when they are pushing on your finger and you felt it's tight, then you know that there is a possibility that this patient could have a defecatory disorder. Right? By right, when you ask the patient to push, they should be open, or it should be lax on your finger. So this patient should then, we need to think about whether she has a defecatory disorder or not. And anorectal manometry will be very useful in order to understand what is that pathophysiological mechanism underlying that so-called defecatory problem, right? Because by understanding this, right, then we can institute appropriate treatment. For example, if the patient has defecatory issues, biofeedback is a really effective therapy. If you look at studies, if you were to institute in an appropriate patient, there is a 70 to 80% chance the patient can improve. And if the patient has a sensory problem, for example, if the patient has a constipation with hypersensitivity, you need to start thinking, could this be a irritable bowel syndrome or not? Then we have drugs like neuromodulators that will be helpful for patients who have a rectal hypersensitivity. So all of these tests are useful to provide a much more holistic interpretation for the patient, right?
Thank you.
You had a question just now? Go.
Does the position of defecation alter the...
Nice.
I myself was finding different way of defecation. Is the position like squatting or sitting? So, and the examination was done while the patient is lying supine. And the balloon expulsion test is done on sitting position.
Yes, correct.
How does it work?
Right. Haha. I'll attempt to answer. Then, Prof, if I get it wrong, then Prof will take over. So the reason why we can do this defecatory test in the left lateral position is just because we are looking at very localized muscle function. We are breaking it down to the individual muscle functions. So external anal sphincter, if you look at the band, you're looking at measuring the rectal pressure. It is also more comfortable for the patient, considering that this will be a procedure that's done over 20 to 30 minutes. Yeah. I also consider that the manometry, the system itself, the instrument itself, it is a tube. It can very well come out. We don't have a balloon that anchors it in position. So if we were to perform the entire test in the sitting position, the probe may actually fall out. Whereas when it comes to the balloon expulsion test, we are actually assessing the manner of them passing out the fecal material. It is a simulated actual defecation, an overall function. Yes, maybe one small component may be impaired. Maybe 2 out of 10 components may be impaired. But what is the overall impression? Can they still pass the balloon out? That is an overall impression. And that's why the London classification, if you have a normal expulsion, you already no longer have any major findings already. But you are right to raise that you are not simulating a very natural position when you are assessing for defecation. Even you talk about defecation in itself, you have patients, the people who are using a squatting toilet, they are less likely to experience constipation compared to people who are on a sitting. Even in a sitting position, do they use footstool or not? So you are right that the anatomy, that the positioning of them affects the outcome of the defecation. But to measure and to get objective testing results, we find that because it's a standardized protocol, we find that when we get the patients in the left lateral position, we are able to get a uniform answer.
Yeah, so I really like the question about the position. What's the ideal position for poop? And obviously, nowadays, our toilets are all sitting toilet. The sitting toilet itself is designed to help our older people to defecate easier. But that is a problem because if you were to sit, then your abdomen has less contribution to the pooping, which I also think is one of the reasons why our younger people have constipation. So during my days, right, my toilets are all squatting. I have no sitting toilets. Yeah, only in the later part of my life, then we start to use a sitting toilet.
Ask the patient to raise their feet,
Yeah.
feet. If you have special stools,
Yeah, footstools.
sitting toilet.
Yeah,
Yeah.
exactly. So now,
So it stimulates walking.
exactly.
Here.
Now you have a sitting toilet, then people design a stool to complement your sitting toilet. And that person make a lot of money just by designing that stool. So you create a problem, you create another solution to that problem. So very clever way of
Should we consistently ask the patient to cough every time we do PR so that we can test at the same time and ask the patient to try to push at the end of our PR?
Yeah, so during the PR examination, usually we ask the patient to do a squeeze and a push. Now, we seldom ask the patient to give a cough, but I suppose so the whole idea is like when we want to see a cough, we want to look at the stress on the anal canal. Yeah, that is the whole idea. Yeah, but usually during the per-rectal examination, that's what we usually do, ask the patient to squeeze and also to do the push, just to give an idea on what would be the defecatory function.
So let's make it common thing to do per-rectal in patients who come with constipation.
Here.
Fully. You don't see that much often then.
No, in fact, I think it's a lost art.
Yeah, I agree.
We should teach our house officer to do it. I don't think our house officer is doing it also. I have a suspicion. So we need to really teach them.
Doing it properly. Yeah.
Yeah.
Doing it properly. Any other questions, guys? Yep, here.
The anal canal, the measurement, the anal
Yep.
canal pressure is
Yep.
it's only for the overlap area, is it?
It's the entire overlap area, yeah. So you remember your internal anal sphincter and your external anal sphincter, there will be a layer of overlap. So most of the time, okay, if I'm wrong, correct me. Most of the time, it's overlapping. You won't be able to see two distinct bands. So like that case where I showed up the anal hypotension, very distinct, correct? That one is a very elderly lady. Most of the time, it overlaps. You only see it interpreted as one general anal sphincter component, rather than, oh, this one intrinsic macam mana, extrinsic macam mana, not so much. Maybe Ra lo, your Ra is all about the intrinsic anal sphincter ma. You push 10 mil already, you see the decrease. Prof?
So sometimes you may find those who have a birth injury, for example, what we call as an oasis, meaning that during the birth process, you might do a episiotomy, isn't it? Now, sometimes, again, if in an untrained hand, when you do episiotomy, if you accidentally cut your external or even internal anal sphincter, you are going to be in deep trouble. Your obstetrician is going to catch you and really scold you, right? Because they need to do a repair at that moment in time. The moment you cut the internal anal sphincter, the patient has a very high risk for incontinence, and they may not even be able to have another vaginal delivery, for example. So for them, right, if you cut the internal anal sphincter, then they need to do immediate repair to preserve the continence. So some of these could be the so-called anal hypotension, could be effect of multiple injuries, right? Together with possible even multiple episiotomies, for example. So that it's always important to ask, why is there a reason behind the anal hypotension, for example? Okay. Great.
What is the other risk factor for young patients to have deficient dyskinesia?
Yeah, another. I think that's a fantastic question. The thing is, you see, when a child poop, right, they learn it by accident. Because parents can never teach them how to poop, right? Correct? So your child can only learn to poop by accident. They either learn it right or they learn it wrong. Correct? Now, if they learn it right, it's fine. Even if they learn it wrong, it's also okay, because as a child, they still have a strong abdomen. They can still push using their abdomen to push it out, no problem. But the problem starts is when they grow up, they grow fat here, they lose their ability to use the abdominal effort. That's when they suddenly realize that, oh, why I cannot poop, I have problem in pooping. So obesity is actually one possible reason, especially in those child that learn it wrong, and you won't know. So dysynergia is actually the wrong way. They really learn it wrong, and they brought it to adulthood, and they only detect it when we do an anorectal manometry, for example. And the biofeedback is a therapy to correct that abnormal behavior. So it's so important to have a right, how should I put it now, the childhood or the problem that the defecation can bring in. So the modern toilet and all of this, right, can influence how your child will develop constipation. Yeah, and also nowadays the school is not helping.
Yeah,
right? The toilet at the school doesn't give an environment like
no man's land.
Yeah. So my daughter never goes to the toilet at school.
Yeah.
She will just tahan until she goes home.
Because there's no door.
Yeah.
All the doors or no lock on the door. So I can go. No door.
Yeah, the toilet is not conducive, you know. So all of this can lead to constipation and so on. Yeah.
How much is our biofeedback program?
I guess it depends on what type. We have the EMG base. We also have the probe base, and the probe base can either be disposable or reusable. So obviously the most cost saving will be those that can be reused. And even if you have the EMG one, you can still use it for a couple of sessions before it cannot be used again. Yeah. So I think the overall cost is not very expensive.
How much do you charge?
Recording. We are recording. later.
Yes.
Yep, go.
Many people were like your doctor, like old until they feel like
Yeah.
at a comfortable
Yeah.
place. I think at least to have a lower volume.
Yeah. So the compliance like you say, right? When you hold, in fact, over time, your rectum may grow bigger, becoming less compliant, and they are not able to feel. That you see, when we want to go and defecate, right, we have that sense, that feeling. For them, right, they will lose that feeling over time. So that is a danger, actually. Yeah, you will tell your daughters.
Yeah.
She's the doctor.
Girls, ladies, girls more than boys. It's there. It's out there. Yeah.
The environment is important.
Agree. Fully agree.
Totally agree.
Yeah.
Exactly.
I have 2 daughters, and yes, this is the thing I'm struggling with. Yeah, actually. Yeah. Okay, for the purpose of the recording, thank you for staying with us, and this will go up on YouTube. If you have watched us all the way until the end, you are crazy. Like and subscribe. Just had to say it, like Hizami told me to say it, so I say it. Okay, all right. Okay, and thank you, and see you in another time.